Okay, so for question number 5, for this set of questions asked to describe the composition of the blood, include components of the plasma and describe the mechanism which blood cells are removed from circulation. So we'll go ahead here and start with blood. So here we have kind of a centrifuge tube. This is what would happen if you were to take someone's blood and put it in a centrifuge and kind of separate all the components. So here, this top section is the plasma, which makes up about 55% of the blood, which contains proteins like albumin, globulin, and fibrinogen. Here in the middle, we have the buffy coat, which is kind of a white, thicker layer that contains the white blood cells. And at the bottom, we have this dark red layer that makes up about 45% of the blood, which is called hematocrit, which contains the red blood cells and platelets and things like that. So if we go over here to blood circulation, we'll talk through how blood is circulated into the body and out of the body. So we start with hemopoiesis, which is the formation of red blood cells or erythrocytes. And so these red blood cells stay in the bloodstream for about 120 days. After they are damaged or they're old, then they will be taken by macrophages and they will be brought into macrophages and will be broken down by lysosomes into their respective amino acids and broken down into the groups of heme and iron groups. And so now we can kind of go down into the breakdown of heme. So this is a little bit of a cascade, kind of multiple step process. So we'll start with the heme in the bone marrow and in the bloodstream. Here we have the red blood cells or the heme that will be broken up into their respective components, which are the iron and biliverdin. And so the iron will be transferred back to the bone marrow by this protein called transferrin. And here we will start with the biliverdin here. So the biliverdin is taken up by macrophages and then becomes what we call bilirubin. Bilirubin will be brought to the liver and will be combined with glucuronic acid to then become conjugated bilirubin. This conjugated bilirubin will travel through the bile duct to the intestine, and that glucuronic acid or the sugar will be consumed by bacteria in the intestine and then become urobilinogen, will be the name after that bacteria takes up that sugar. So 10% of this urobilinogen will go to the blood and about 90% will continue through the colon. So going to the colon, there will be bacteria in the colon that converts this urobilinogen to stercobilin, which then goes into our feces. The 10% that goes into the blood will then be filtered through the kidneys, which will then become urobilin, which has that distinctive yellow color, which is part of our urine. And so that is how the heme in our blood is broken down after the red blood cells are used throughout those 120 days. Now, what we will do is talk about hemostasis, which is how the body regulates the damage or loss of blood. So the first one we'll talk about is vasoconstriction or vascular spasm. So what happens here is if the body gets damaged, the blood vessels get broken or things like that, the pain reflexes will trigger the nervous system and they will send signals to the smooth muscle of the blood vessels and cause them to contract. So there will be a signal sent to the smooth muscles of the blood vessels and they will contract, restricting the amount of blood that goes to that area to prevent further loss of blood. And so this solution is temporary and it cannot establish hemostasis alone because it can only hold the blood vessels closed for so long and will not cause a long-term fix. This is just for as soon as that damage happens to keep it from bleeding a lot. The vasoconstriction will happen. So now we'll talk about more long-term solutions and long-term hemostasis. by first talking about the platelet plug. So what I've drawn here is the inside of a blood vessel. Here in blue, we have the basement membrane, which is negatively charged here, and in red, the epithelial cells along the blood vessel. So here in this section right here, I've shown the damage of a blood vessel. The epithelial cells will be damaged. So here in green, these little green dots floating in the blood, we have the VW factor. And in a non-damaged blood vessel, they don't do anything. So you'll have platelets and this VW factor kind of floating throughout the blood when all is going well. But when there's damage and this opening happens, the VW factor will come in and will bind to this negatively charged basement membrane here. And so once these are all bound to this negatively charged basement membrane, the platelets will come along. So here is a regular platelet. It's kind of this circular shape, and here is the shape of a more activated platelet. And so now we'll talk about the things that are on platelets. So here in green, we have GP1B receptors along the platelets. We also have GP2B receptors here in red on the platelets. Inside the platelets, we have in the orange the alpha granules, and the purple we have dense granules. So the process happens when the blood vessel is broken, the VW factor binds to the basement membrane. And these platelets, the GP1B, will bind to the VW factor that's on this membrane and will cause the platelet to activate. When the platelet is activated, it will release all of these granules, these alpha granules and dense granules, and that will be released into the blood. And these granules will go and they will activate other platelets that are nearby, this one right here. And these red GP2B receptors will bind together with other activated platelets using this protein fibrinogen that is right here between these platelets. And so as each platelet is activated and they release their granules, it will activate nearby platelets and they will then collect right here. A lot of activated platelets will come in, collect right here where this damage is, and that will be what we call the platelet plug. It will plug up that damage and stop the blood from continuing to leak out. So now the third and final aspect of hemostasis is what we call the clotting cascade. And so this is kind of the pathway by which each one of these factors will go through the different type of clotting to establish this homeostasis. So here, if we have surface contact, this is first the intrinsic pathway. Here, everything outlined in blue. So we'll go through this. If we have a surface contact, that will change our factor 12 to 12A, which will cause our factor 11 to change to 11A, our 9 to 9A, and then from our 9A it will need to be activated by factor 8, PL, or calcium. That will activate this factor, which will cause factor X to go to XA or 10A. And so that is our intrinsic pathway. Our extrinsic pathway on the outside is here we have the tissue damage, which is kind of what we went through in the platelet plug. And that tissue damage with the factor 7 will go ahead and cause 7A to become activated, which will then come down to this part of the cascade where we take 10 to 10A, which is also activated by factor 5, PL, and calcium to take 2 to 2A, which will allow, here we have 13 to 13A right here. We'll have 1 to 1A to a stable fibrin clot. So a few of these that we need to know is that 2 here is prothrombin, 2A is thrombin, 1 is fibrinogen, and 1A is fibrin. So a couple different things here. We have different proteins in the blood. This is plasminogen, which can be activated by urokinase to form plasmin. And what plasmin does is it eliminates this fibrin. It breaks down the fibrin of the clot. So after the clot has done its job and after the blood bleeding is stopped, this plasminogen becomes plasmin, which inactivates this fibrin and causes the breakdown of the clot. To go the other direction, we here have this enzyme TPA, which will cause our plasmin to go back to plasminogen, which is important for the formation of the clot itself.